I am a consultant for Ceribell, and I work with their labeling team and physicians and staff to advise them on clinical use of the Ceribell. I'm a contributing author for clinical trials for Ceribell or for associated technologies in machine learning for EEG. And I'm happy to report my bias on this. I'm a biomedical engineer, and I am inclined to study technologies that increase access to care, especially if they augment clinical skill to reduce error or enhance our ability to detect a disease signal, and I'm all on board that train. So complications of COVID-19, Dr. Greg Damberger from the University of New Mexico, earlier in our speaker series, was kind enough to provide this review showing how in severe disease we see excessive inflammation leading to an exaggerated immune response and neurocomplications. Now, we all know that ICU-dependent neurological symptoms are very common. We see delirium, ARDS, hypoxemia, sedation. But the question that we've been really struggling with in the critical care community has been is there a COVID-dependent neurological disease or neurological disease presentation? We're seeing these reports as was just referenced. We're seeing stroke, hyperperfusion, encephalitis, meningitis, and some of the things a lot of us are really concerned about, which is the post-viral syndrome we haven't even really come to terms with yet, Guillain-Barré syndrome or exertional neuropsychiatric illness like chronic fatigue. What we really want to try to find out is, can EEG identify a treatable illness in COVID-19? Early case series out of China showed a lot of patients enrolled. These are some oft-quoted studies, this one and the next one. I'll skip the details because they're better presented elsewhere, but what I want to point out is in these studies, we see that they say in black and white, to avoid cross-infection, diagnosis of nervous system manifestations depend on the subjective symptoms of patients and examinations. In short, they did no EEG, they did no MR imaging, and they did no lumbar puncture. In a study out of a multi-institutional study in China, including in Hebei, which is where Wuhan is, new onset symptomatic seizure and risk factor for coronavirus disease. They were trying to identify whether risk factors for seizures would show seizures. They enrolled over 300 people. They had 27% with what they called brain insults. But if you look closely, someone who had experienced hypoxia was said to have suffered a brain insult, not with any evidence of brain injury that would lead to, for example, a risk of seizures. Anyone who was septic. What they say is no routine or long-term EEGs were studied. There were none recorded due to exposure concerns, and no brain imaging was done or reported. So in a case series that did involve neurological complications, it was a little bit better done. This is out of Strasbourg in France. They had 64 patients with ARDS, 58 of whom had neurological signs. It's 84% of their patients. All 58 of them were sedated on some combination of fentanyl, mostly Versed. Encephalopathy at just under 70% was the one that they had seen the most at about 4 days out. But a lot of them had concerning cortical spinal signs. 13 of those people received an MRI, and 100% of the people who received an MRI had bilateral frontal temporal hypoperfusion on diffusion-weighted imaging. 8 of the 13 also had leptomeningeal enhancement, and 3 strokes were seen. Of those 58, 8 of them received EEG. Now, most of these showed the nonspecific exchanges you'd expect to see, slowing, but one of them did have diffuse bifrontal rhythmic delta activity. A multi-institutional study in Turkey across 7 hospitals in Turkey and 1 in the United States in Iowa, just published in the Journal of Radiology on May 8th. They were trying to specifically look for MRI findings in patients in the intensive care unit, so patients with severe presentation of disease. They looked at 230 people. Now, there was some enrollment variability. Some institutions were a little bit more or less inclined to put someone in the MRI. Other places had a more severe presentation of disease where everybody who was in the ICU had COVID, basically. But what they were really looking for was someone who was RT-PCR positive for COVID, who failed to wake after 48 hours off sedation, who did not have CT evidence of a stroke or hemorrhage. So of those 50 with neurological symptoms, 54% received a brain MRI, and 12 of them, that's 24% of total, or 44% of the people who had received an MRI. So just under half of the people who received an MRI with neurological symptoms had an abnormal MRI. The findings that they had increased DWI signal, typically frontal. 7 of those had perfusion mismatch on ADC. Cortical flare signal was seen in an equal number of them. Basically, the same patients who had frontal or hypoperfusion also had flare signal. And they only gave contrast to 8 of those, but 5 of the ones they gave contrast to had leptomeningeal enhancement again, and there were subcortical findings as well. Here's one of those patients. So this is 58-year-old male on day 0. Day 0 is the first day where it has been 48 hours since they have not woken up. And what do we see? We see cortical, subcortical flare signals diffusely. We see frontal diffusion-weighted changes, and we see left meningeal enhancement. Now on day 6, this patient has gotten better. They've also improved clinically. They've got reduced flare signal. They've got resolved diffusion-weighted imaging, and they've got no contrast enhancement. Here's another patient, basically the same story. 48-year-old male, day 0. We see cortical flare signals again. We see frontal TWI signals again. And this person didn't have enhancement, but they did have some visible cortical hyperintensity in contrast enhanced images. And 7 days later, stable flare, resolved DWI, and reduced hyperintensity on contrast enhanced images. This was an interesting study. It is a preprint, so it has not been peer reviewed. It's included here because it's a post-mortem study. So these are people who did not survive COVID. And it's included because as an imaging study in patients who are now expired, there's a pretty narrow window of interpretation there that obviously I think should go through peer review, but I think we can learn a lot from what they found. So they had 19 patients with post-mortem imaging at less than 24 hours, 2 to 24 hours after they expired. Now there were 9 patients there were 11 individual findings reported, and there were 9 individual patients for whom pictures or a list was put in the paper. It's not clear to me whether there were 11 distinct patients or whether there was some mismatch for 1 or 2 of the findings. But what do we see? We see there were several patients, this is just one of them, with diffuse punctate hemorrhages or diffuse, not even punctate hemorrhages throughout on SWI imaging. Again, we see cortical and subcortical flare imaging throughout, and this person has gyral encephalitis, precentral gyral encephalitis. We see subcortical flare findings in this patient, and this was an interesting one. There were 4 patients who had asymmetric olfactory bulbs with inflammation of the olfactory bulb. This one actually has invasion of the cleft, and you can see actually where the sinus is filled here, and there's tissue swelling. So let's talk about seizures. Now, case reports are pretty sparse for the reasons that we talked about. And there's a lot of reluctance on some people to order studies and for other departments to do them. So we start off with some of the cases. This was a patient in Florida, a 74-year-old came in. He's got a remote history of left temporal stroke, 7 days since he started having a dry cough. He came in, they thought it was a COPD exacerbation, so they gave him antibiotics and sent him home. The next day he came back, he's severely altered, he's obtunded. A CT scan shows new right temporal hypodensity, and he was RT-PCR positive with a nasopharyngeal swab, and we see this right temporal hypodensity. You can also see his left temporal remote stroke. An EEG was done that day, which showed left and right, which showed bilateral temporal spikes, right greater than left. And so you can see the left is on the top, the right is on the bottom, and we see rhythmic delta waves, and we also see right temporal spikes and also some on the left. This patient was somewhat similar. Seizures as presentation of COVID. Didn't have cough, didn't have anything else. It's an Italian woman, 78 years old, who has new myoclonic jerks in her face and her upper extremity. Now, she did have a history of herpes encephalitis, non-convulsive status in 2016, but she's been controlled for over 2 years on valproic acid and Keppra. Now, interestingly enough, she had her normal surveillance EEG 10 days prior to admission. Had nothing to do with COVID, had nothing to do with any symptoms. It was just her normal annual surveillance EEG. And that was completely normal. In fact, we don't really see any slowing, even in the area that we will later see. She has considerable encephalomalacia on her left side. But now she presents for the first time focal status epilepticus. She's got focal myoclonic jerks on the right. This is her EEG then. What do we see? We see semirhythmic high amplitude delta waves, and we can see a lot of superimposed myogenic muscle artifact on the right. It may be hard to see here, but this is FP2C4, and this down here is FP1T3. Here are the spikes and the waves pointed out. Now, 12 hours after presentation of her seizure, then she developed a fever. Because of the fever, she was tested, RT-PCR nasopharyngeal swab was positive. She had no other COVID symptoms. Case tracking would show that her son was also sick, and she had seen him 3 days prior to presentation. So this is an interesting case where seizures was the primary feature. So here you can see an example of her MRI showing that there's none of the DWI or flare images, and you can see her chronic encephalomalacia. But what about a non-lesional patient? So this is someone who has a normal brain MRI. This is in France, a 59-year-old male who's got other comorbidities, presents typically headache, fever, cough, intubated quickly, and a rather typical progression for, unfortunately, some of the severe presentation of COVID we've seen. His first 2 RT-PCRs were negative, by the way, but tracheal aspirate was positive. On the 10th, so after 12 days of being in the ICU, he's got fluctuating encephalopathy. He's alert, but he's got short episodes. They describe it as seconds to less than a minute of confusion. EEG was done. We can see it's quite abnormal. He's got bifrontal spikes. This is the right on top and the left on the bottom. He's got rhythmic delta activity. And again, his MRI was normal. And here's some of that more pronounced EEG activity that's pointed out. So just a summary of early COVID-19 studies. Data collection's rare. Big studies that are reporting neurological symptoms in general or talking about seizure in specific, no EEGs are conducted. They're concerned about safety studies. In case series that look at MRI findings, we see a high percentage of MRI findings among patients who have neurological features and a low number of EEGs conducted. And then among case reports, we see where seizures are suspected or altered mental status is seen. We're starting to see some consistency with rhythmic delta, bifrontal slowing, and some spikes. But we need more data, obviously. So we need safely conducted, prospective EEG studies. First one that started to add to this was from the Einstein Medical Center in New York City, published in Epilepsy in the first week of this month. EEG findings in acutely ill patients with novel coronavirus. They were evaluating the prevalence of abnormal findings in persons with COVID positive versus COVID negative. So these were patients who were under investigation, PUI, for COVID-19, but had not yet been confirmed, who had clinical encephalopathy or maybe some type of seizure-like event. The 28 persons that were under investigation, 22 of them would later test positive for COVID and 6 would not. Now, it's worth mentioning, 4 of the people who eventually tested positive for COVID had pre-existing long-standing epilepsy of one kind or another and may have been on AEDs, half of them were. 26 of these people received a Ceribell average 165 minutes. And then there was a mixture of either continuous or routine EEGs done across them. Some of them were converted and a couple of patients had traditional 1020 EEGs only. Now, there's a lot of data on here, but what I really just want to draw your attention to at first is there's really not much difference in the background slowing between those who eventually tested positive for COVID and those who did not. So what we see is that 100% of them are slow as we'd expect if they're sedated or they're in the ICU. Now, although they didn't have enough power to detect an effect in a difference between what ended up being 22 positive patients and 6 negative patients, what they do show is that sporadic epileptiform abnormalities, spikes or waves, typically frontal sharp waves, were present in 41% of persons who eventually tested positive for COVID-19 and 17% of persons who were negative for COVID-19, with the preponderance of those being frontal sharp waves. Now, they're also quick to point out that among the persons who were COVID-19 positive, there was a higher suspicion of clinical seizures or presence of discharges in what eventually became the COVID positive group, owing most likely to them having a more severe illness. The reason why they mention this is because they started anti-epileptic drugs early before the EEG was started in over 75% of those patients. So what this means is that we see a difference of 41% versus 17% in this low power study. But this number is likely higher because a significant number of those patients, well, I should say a larger preponderance of those patients, received anti-epileptic drugs, which almost certainly reduced the discharges. Among those that the discharges were seen, we saw mostly periodic rhythmic discharges, frontal rhythmic delta, and some sharply contoured waves. Here's an example of one of the patients who has some periodic sharp waves with frontal predominance and some rhythmic delta activity. This is from the Ceribell. The Northwestern study is one that's going on now. We were very happy to see, I was very happy to see Stefan Schul present this data from Northwestern earlier in the week as part of our speaker series. Data collection is ongoing. They've got 14 patients so far with an average of 10.5 hours for having Ceribell. The indication is moderate to severe encephalopathy in COVID-19. Their abnormal findings are 100%, as you can expect, because these are moderate to severely encephalopathic, so they're diffusely slow, but they are also seeing periodic triphasic waves and, again, intermittent rhythmic slowing. Let's look at a couple of patients. First, patient number 1, intermittent rhythmic slowing. This patient first had Ceribell, and then they were advanced to full montage. So what they saw was this intermittent rhythmic frontal predominant slowing that we've seen in a couple of patients before. The patient was, again, advanced to a traditional 1020 system, and here's the full montage where we see the same bifrontal rhythmic delta activity that we had seen earlier when the Ceribell was in place. This patient number 2, rhythmic triphasic waves. This is a highly epileptiform pattern. So the Northwestern is using another technology from Ceribell called Clarity that uses a machine learning technology to survey a rolling epoch for highly epileptiform patterns. And what we see here, this blue line is the cross-sectional that represents this epoch that's visible on the screen. And on the y-axis, we see the burden of epileptiform patterns, with red being the area where we're seeing it now, that we would expect, a reader could expect to see more epileptiform burden in that area. So what we see here is periodic rhythmic triphasic waves that are abutting right against the electrographic definition for seizure. Enough so that at this point, I think most epileptologists would say that clinical findings should predominate when it comes to medical decision-making, and many epileptologists would choose to treat this patient. So in summary, what do we see for EEG and MRI findings? First of all, the studies that have been out there are weighted towards severely ill patients. I mean, 19 of the patients that were received MRI were already expired. But that makes sense, because these are the patients that are so severe that even physicians who might be reluctant to do EEG and MRI really felt that they should. What did we see? MRI signal is common. When they actually do look, it's common. It's in nearly half of the patients that were shown that had EEG, that had neurological findings. We mostly see diffusion-weighted frontal hyperperfusion, cortical and subcortical flare imaging, leptomeningeal enhancement when contrast is used, and olfactory invasion and swelling, which explains some of the anosmia that we have seen reported clinically. EEG findings are common. 100% of them are diffusely slow, basically, which is to be expected. So that's not even abnormal for a patient who's severely encephalopathic. What we are seeing is frontal rhythmic delta waves or triphasic or periodic sharp waves, again, often with a frontal predominance. Now, we could also look and see that focal slowing, we know, is associated with a structural disruption. So a patient who has diffusion-weighted hypoperfusion in the frontal lobes is going to may very well have focal slowing, but an MRI is more difficult to get. So I see this, and I see that there's a conspicuous lack of EEG studies given the MRI findings, and this may suggest a care gap.